Hello, welcome back. So today we'll be discussing HRCT imaging, with showing pathologies with increased parenchymal lucency. So this will be a second discussion under the approach to chronic cough and hemoptysis. Importantly, this is also a topic that is accompanying our general discussion on HRCT imaging, and that is these two are in continuation with each other. It just depends on the approach with which you are studying these topics. So from an internal medicine point of view, patients with hemoptysis, as we've discussed in our previous lecture, are likely to have conditions such as bronchiectasis and lung abscess, and therefore may show lucent areas within the lung. So that is why it is under this heading. However, the same could be said from a radiology point of view. These two discussions could be in continuation with each other in terms of HRCT imaging of decreased parenchymal lucency and increased parenchymal lucency. Okay, either way, see, that setup remains the same. The patient is placed inside a CT scan machine. This is the third generation CT scan machine. So the source and the detector, they rotate together, as I've discussed, around the patient. Okay, and this is our schematic of the lung that has been placed inside the CT scan machine. This is as I've discussed previously. So now past X-ray beams through the lung, and I've represented a small, actually size accurate bronchopulmonary lobule. Now again, the anatomical constraints of our system again remain the same. So like I discussed in our other HRCT discussion, this is our enlarged view of the bronchopulmonary lobule containing the pulmonary artery branch, the lymphatics. These are the green structures here, and as we've discussed, they pass through the base of the bronchopulmonary lobule, or the hilum of the bronchopulmonary lobule, and through the septa, as well as the blue structures represent venous drainage, and they pass exclusively through the septa. The respiratory tree that is branching within the bronchopulmonary lobule is represented in pink. Okay, so this remains the same. Now we passed X-ray beams through both these structures, and then we get our cross section. So the cross section again obviously is the same. I pass an X-ray beam through the bronchopulmonary lobule. It gives me a cross section that looks like this. So this is our bronchopulmonary lobule inside cross section, and you can see the veins and the lymphatics are present in the septa. The lymphatics and the pulmonary artery branch, as well as the branch of the respiratory tree, is located in the center. Okay, obviously the lymphatics and the pulmonary artery branch would therefore also juxtapose the visceral pleura or any fissure that is present within the lung. As we've already previously discussed, this is not what we actually see because of the limits of resolution of CT. So a CT scan machine at its highest resolution is able to delineate points that are around 1 millimeters separated from each other. However, what we find here is that these structures, the septa, the small lymphatics and veins, are smaller than that. Because they're smaller than that, they are not perceptible. The only structure that is routinely perceptible, or actually sometimes perceptible rather, is the branch of the pulmonary artery that is located at the center of the lobule, and I've given it a red color, but obviously on a CT scan it looks white. So now coming to our topic at hand, that is mechanisms of decreased lung attenuation. So decreased lung attenuation is defined as when you measure the actual attenuation, a Hounsfield unit value that is minus 1000 to minus 900, and the scale goes from minus 1000 to plus 1000. Okay, so this is the lowest possible value. So there are three possible mechanisms by which this could happen. Okay, it is air that has got a HU of minus, a Hounsfield unit value of minus 1000. So when I say that something is approaching minus 1000, it probably means that there is a increased ratio of air to tissue within that area of the lung. Correct? So why would that happen? The first possibility is that the air is actually increased in amount. So that happens when you have air trapping. So what does that mean? That means during inspiration, see, I've represented a small ball valve mechanism in the alveolar duct here. During inspiration, air is allowed to come inside into the alveolus, but during expiration, the structure or whatever is obstructing the lumen of the alveolar duct blocks it, and therefore air is not able to leave. So with each inspiration, a little bit more air comes in till the time there is enough pressure within the alveoli that it starts to stent the alveolar duct, and then air can leave during expiration also. But now that much pressure is required to keep the alveolar duct patent. So this alveolus is more distended than it would be during expiration. So air trapping, okay, is an expiratory phenomenon and should be described only in expiratory CT scan. So we can take a CT scan both during inspiration, okay, and during expiration. So it is only a finding in expiratory CT scans. Okay. Now the other possibility is, and this is when you have areas of lucency within your inspiratory CTs, what could happen is, or what is happening is, that the tissue is decreased. So the air is not increased, but the tissue with the amount of tissue that is there is decreased. Now there are two types of tissue within the lung. There is the lung tissue itself, and then there is blood that is coming in. So either you have a decrease in the pulmonary parenchyma. Okay, so this is due to some structural abnormalities in the pulmonary parenchyma, resulting in the formation of either a cavity or the proximal airway dilating, or as I have shown in this example, the formation of a cyst. Okay, so cyst formation, cavitation, or a bronchiectasis. On the other hand, there could be a decrease in blood flow. Now see, this is a normally ventilated alveoli. Okay, so what has happened is that there is actually an obstruction that is preventing blood flow to the alveoli. Now this blood is also tissue within the lung. So as a result, the ratio of air to tissue becomes skewed towards air. Okay, even though the amount of air that is there is normal. So these are the three mechanisms by which there is decreased lung attenuation. Now let's just talk about this a little bit more in detail. So when we talk about air trapping, what might be the causes? So air trapping, like I've discussed, this is in an expiratory CT. Okay, only in an expiratory CT. So what may be the causes? So obviously there is some obstruction somewhere. So this obstruction could be at the level of a proximal airway. So that could be in the proximal airway, it could be a focal obstruction. Okay, a focal obstruction could be a mucus plug, it could be foreign bodies, it could be an endobronchial mass, even atresia or stenosis of the proximal bronchus. Okay, the entire thing. So this would result in air trapping in that particular lobe. That is what is specific. Okay. Now, on the other hand, you could have diffuse involvement of multiple proximal airways. And I just want to introduce a mnemonic that will be a recurring theme in our discussions. So that is cigar. Okay. So cigar is actually a mnemonic I use for recalling the immunological entities or systemic autoimmune rheumatic diseases and related diseases that result in mass formation. Okay, so that produce masses within the body, and that stands for sarcoidosis, usually IgG4, but in this particular case infection, G for GPA or granulomatosis with polyangiitis, A for amyloidosis, and R for relapsing polychondritis. So I've modified it slightly for the sake of endobronchiolar or bronchial mass lesions, in that IgG4 typically doesn't affect the internal diameter of the airways. So here it is an infection, usually infections that produce mucus plugs. Okay. Additionally, there is an extremely rare entity called tracheobronchopathica osteochondromatosis. Okay, and as you can see, it's a mouthful. So it's a radiological entity where you get the tracheal bronchial tree. There are multiple calcific growths within the lumen. Okay, and that can compromise the lumen to an extent. Now, the other thing that might happen is you may have a distal airway occlusion. So distal airway occlusion, obviously one prominent situation in which that is there is, we've already discussed in our previous HRCT discussion, that is a centrilobular nodule. So this would obviously be a centrilobular nodular interstitial pattern due to obstruction of the airway. Okay, not due to involvement of the pulmonary artery branch. Okay, now the other possibility is that you may have airway disease due to asthma, bronchiectasis, or what we call bronchiolitis or constrictive bronchiolitis. All of these entities together, they are termed small airway disease. and we'll see in the next slide what is small airway disease. So relapsing polychondritis and tracheobronchopathic osteochondromatosis, these two entities exclusively affect the cartilage parts of the trachea. Okay, so therefore the posterior half of the trachea, or the posterior the trachealis muscle per se, will not be affected. That is something that we can see on imaging. Now, however, there is a very important point to be noted here. I have actually created a list that is not really representative, because as you can see, out of cigar there is only one entity is infection, that is non-tubercular mycobacteria and or ABPA, that can produce enough mucus to produce a ball valve mechanism. The others are actually wall thickening, so they will not produce air trapping. So rather the list is like this. So as you can see, air trapping is caused by only either a proximal airway endobronchial lesion, mucus plugging as a result of infection, or what we call the large group of small airway diseases. Okay, small airway disease. These are actually the only three causes of air trapping. And again, reiterating, this is an expiratory CT finding. It is an exclusively expiratory CT finding. Okay, so as the representative examples, even on a chest X-ray, you can see that there is a mucus plug within the proximal right lower lobe bronchus. Similarly, in this CT, you can see that there is a sessile mass within the trachea. Now, masses within the trachea are extremely rare, and most are neoplastic, malignant. And see, the discussion is beyond the scope of the present discussion. I'll be getting to malignancies and oncology at a later date, so we'll be discussing it at that point. Now, air trapping is a radiological entity which is one of the defining features of what we call small airway disease, or SAD. Now, SAD here is represented by air trapping, and here you can see there are areas of increased parenchymal attenuation. Okay, and there are juxtaposed areas of decreased parenchymal attenuation. And importantly, the diaphragm is elevated here. So this is actually an expiratory CT during patient's expiration. And you can even see the posterior wall of the trachea coming anteriorly and coming into a coronal section. So this is definitely an expiratory CT. And again, air trapping is only described in an expiratory CT. It is only an expiratory CT finding. So these are areas of the lung parenchyma that do not show the expected increase in parenchymal attenuation in expiratory images. So during expiratory images, as air is expelled from the alveoli, obviously the ratio of the air to the tissue within a particular voxel, or a particular voxel within the CT image or data acquisition, would decrease. Okay, so the air signal is decreasing, therefore the attenuation would naturally increase. So it is expected. This is a normal finding. If that does not happen, that is what we call air trapping. The other defining feature of small airway disease, and we'll go into this again when we discuss sensitivity pneumonitis, is a ill-defined central lobular nodal interstitial pattern. These are the two things, and we've just discussed this in the previous topic. Now let's talk about pulmonary hypoperfusion as a cause of decreased parenchymal attenuation. So see, just based on the distribution of the hypoattenuation attenuating areas, it may be that the areas are symmetric and they are present on both sides. So in that situation, it is probable that the pulmonary vasculature is affected in multiple areas. So the likely pathomechanism may be there may be multiple thrombosis in different areas, there may be vessel inflammation at various areas, and there may be a hemodynamic problem that might be causing complete reduction in the blood flow into the entire pulmonary artery tree. So in the case of thrombosis, it would be a chronic thromboembolic pulmonary disease. Note, this is not chronic thromboembolic pulmonary hypertension. The PH designation of the pulmonary hypertension is only if there is pulmonary hypertension. We'll come to that in our pulmonary hypertension discussion. So the second thing is vasculitis, and we've discussed this already. Vasculitis affecting the pulmonary vasculature is exclusively due to Takayasu aortoarteritis or Behçet's disease. Okay, and finally, decreased pulmonary flow might occur with either proximal or precapillary pulmonary arterial hypertension, or it may happen with a RV systolic dysfunction of the right ventricle. And the RV systolic dysfunction is exclusively due to PAH causing heart failure or RVMI. Okay, fine. Now the next thing is asymmetric or unilateral. So significant asymmetry may occur if there is a single thrombus or just a few thrombi. So this usually happens with acute pulmonary embolism. It may happen with vessel wall lesions that are invasive. So something invading the vessel wall, like a invasive aspergillosis or even a vessel wall angiosarcoma. Okay, such things, or pulmonary artery angiosarcoma or sarcoma. Now the last very important thing is, sometimes what can happen is that the one of the pulmonary veins is draining into the right atrium instead of the left atrium. So because of that, they are actually draining into a atrium that has a lower pressure. Okay, so because the pressure in the right atrium is lower, the flow is directly proportional to the difference in pressure divided by the resistance. Okay, so essentially what is happening is that the pressure is decreasing. So as a result, the flow rates are decreasing. So blood doesn't stay in the pulmonary capillary bed, and therefore that area shows hypertension. So again, this is something that is more of a radiological consideration, but see, when analyzing an image, this may be a incidental finding, and this is something that an internist also needs to appreciate. Okay, now the term mosaic attenuation is actually very distinct from air trapping. Okay, it is a descriptor used only in inspiratory CT. Okay, so as you can see in all of the CTs that I will show you now, the diaphragm is down and the trachea is patent. So even in an inspiratory CT, you can see there are areas of increased attenuation, and surrounding there is an area of decreased attenuation. And notably, see the borders, they are very sharply demarcated geographic borders. Okay, looks like the borders of country. Now similarly, this is another condition in which you see areas of intervening, I hope it is visible, intervening increased attenuation, but I can't really sketch them out. So it's ill-defined mosaic attenuation. Then there are very few patches of mosaic attenuation that look very similar to our geographic mosaic attenuation, but are significantly fewer in number. This distinction is not very significant. It's just a distinction that I make while. And very importantly, here, if you notice in the geographic mosaic attenuation, the vessels that are going into the hypoattenuating area, those are smaller in size than expected. Okay, whereas here in the patchy mosaic attenuation, the vessels are not significantly smaller. They are not universally. Okay, we'll see why. The mechanisms will make it clear. Geographic mosaic attenuation describes well-defined areas of hypoattenuation with sharply demarcated borders. The GGO represents adjacent areas of hyperperfusion with engorged vessels. So the adjacent areas show hyperperfusion. Ill-defined mosaic attenuation is the areas of hypoattenuation with poorly demarcated margins with an upstream vessel showing normal caliber. Okay, and you usually have, as we've discussed, this is a finding of small airway disease. So you have centrilobular, nodular, interstitial opacities that are also prominent. So this patient on an expiratory CT may show air trapping, and that would be called air trapping. Okay, so this is different from mosaic attenuation. Air trapping can go along with ill-defined mosaic attenuation in the inspiratory field as well. Now, patchy mosaic attenuation is due to a proximal airway problem. So during subsequent imaging, you might find that the proximal airway problem is corrected, and therefore the distal air alveoli are no longer hypoxemic, and therefore that is not causing vasoconstriction anymore, and that resolves. So the resolution is actually the main feature that differentiates it from geographic mosaic attenuation. Okay. Now, decreased pulmonary parenchyma may be the result of three structural abnormalities. That may be bronchiectasis or irreversible dilatation of proximal airways. It may be emphysema. Okay, it might be cyst formation or cavity formation. Now, in case of bronchiectasis, what we find is that the bronchiolar lumen dilates irreversibly. So, as a result of that, what happens is the diameter of the bronchiole in relation to the accompanying branch of the pulmonary artery becomes enlarged. So normally they are usually equal in size. So now what happens is that the bronchiolar diameter exceeds that of the pulmonary artery diameter, and the combination of a pulmonary artery branch along with its accompanying dilated bronchiole produces a ring-like image on cross section, and that we call a signet ring sign. In longitudinal section, that would produce a tram track. Okay. the presence of dilated airways within 1 to 2 centimeters of the lung periphery also indicates that it is bronchitis. Now, emphysema is essentially just the presence of air-filled structures within the lung with imperceptible walls. So the wall of the structure is not clearly visible. Depending on its distribution, it may be centrilobular. Now, centrilobular emphysema is usually the result of smoking, age-related lung changes. Paraseptal emphysema, unlike centrilobular emphysema, also involves the pleural surfaces and the fissures. So centrilobular, just like centrilobular nodular interstitial opacities, would spare the or be repelled by the visceral pleura and the fissures. Okay. Now, Parenchymal emphysema is essentially involves the entire bronchopulmonary lobule, and it is characteristically described in the context of alpha-1 antitrypsin deficiency. Centrilobular emphysema is also described in a genetic disorder that is called Sala's disease, and this is something that usually internal medicine residents are not aware of. So Sala's disease is actually also called Finnish type sialuria. Okay, so it is an autosomal recessive disorder due to a mutation in SLC17A5. Okay, so this is something that we usually doesn't come up during internal medicine round discussions or while reviewing even in Harrison mostly. So it's just a very small description in the table on genetic storage disorders. However, it is in this context it becomes relevant, so it is something that you must be aware of. Now, what is the difference between paraseptal emphysema and honeycombing? So essentially, they are exactly the same. Wouldn't they be the same? Yes. So honeycombing, as we've discussed, represents multiple cysts, usually with perceptible walls that are typically 2 to 10 millimeters in diameter and are present in 1 to 3 rows in a subpleural distribution. Now, paraseptal emphysema also is in a subpleural distribution. They are also air-filled cavities. Their wall is by definition not perceptible, but when multiple cavities are right next to each other, the wall may become perceptible because you got air on either side. So how do you differentiate it? So obviously honeycombing occurs in the context of a deflated lung. That is, it is a restricted lung. It's a lung with restrictive pulmonary mechanics. Whereas obviously paraseptal emphysema happens in a lung where the expiration is impaired. So as a result, the total volume or the residual volume of the lung is actually increased. Okay, so that results in increased lung volumes, and that has two morphological findings. One is that the trachea tends to start becoming compressed from either sides as the lungs inflate. So that produces a characteristic decrease in the transverse diameter in relation to the anteroposterior diameter of the trachea, and you get this appearance of the trachea, and that is called a saber sheath. Okay, it looks like the cover of a saber or a sword. And the other thing is the diaphragms start to get compressed. So as you can see that on a lateral x-ray, the diaphragmatic dome should be more than 1.5 centimeters above a line joining the posterior end of the costophrenic angle and the anterior end of the costocardiac angle, this angle. Okay, so a line joining these two, above that it should be more than 1.5 centimeters above that line. That is the tip of the dome, or the highest portion of the dome should be 1.5 centimeters above that line. So this, if it is less than that, then we say there is diaphragmatic flattening, and that in combination with your saber sheath trachea indicates that there is some degree of increase in lung volumes. That's how you differentiate it. Okay, so that is called hemidiaphragmatic flattening. Now coming to the last entity, that is your cyst. Now cystic lung disease is evaluated in the context of how many cysts are there. So then you may have a single or a very few number of focal cysts, or you have multiple or multifocal cysts. Okay, now why? Because the differential diagnosis differs. So the other thing is it a true cyst or not? Now we've already discussed the definitions of emphysema, of honeycombing, okay, and of cystic bronchiectasis, and we will be discussing the definitions of pneumatocoel cavity in bullae. So then you have a single or a focal cyst. It is these three entities that are possible differential diagnosis. So how do we differentiate them? So how we differentiate them is as follows. We we will do a comparison. A cavity is one, it has a thicker wall. So a cyst is by definition has a perceptible but very thin wall, usually 1 millimeter by definition. Okay, whereas a cavity has a thicker wall of more than equal to 2 millimeters. And usually because it is thick, it is irregular. So it's an irregular and thick wall. Bullae are usually very large in size. They are not small like cysts. Okay, cysts can also be large in size, but typically the largest of cysts are less than 1 millimeter, 1 centimeter in size, 10 millimeters in size. The other thing is bullae are found in the spectrum of emphysema, so their walls are imperceptible. Okay, the last is a pneumatocoel. A pneumatocoel is a very thin wall, that is, their wall is imperceptible and round structure, usually very small in size. And by definition, pneumatocoels are transient. Okay, they are due to transient air trapping, which resolves over a period of time. And usually they are associated with adjacent consolidation and gigio. That is not a very big differentiating feature, because we'll see that associated gigios are a finding that help you diagnose cystic lung disease, okay, and the cause of cystic lung disease. But that is the finding. Okay. On the other hand, emphysema, honeycombing, and cystic bronchiectasis we've already discussed. The only thing I would like to highlight is cystic bronchiectasis, because we've not discussed it as a separate entity. So cystic bronchiectasis will show air trapping, which would be on what? It will be on the expiratory CT. Okay. Second thing is, see, it is cyst formation along the wall of a branching respiratory tree. So the cysts show a branching pattern. They form along branching respiratory tree. The third is that there will be thickening, because we'll discuss when we discuss bronchiectasis, there is actually a inflammation and a structural change within the bronchial wall. So that results in a bronchial wall thickening. And finally, we have, along with this, obviously it's an airway problem. So you may get a centrilobular opacity, okay, not an interstitial pattern. The others, the things we've already discussed. Now, once you are sure that it is not any of these things, and you have a multiple or diffuse pulmonary cystic disease, okay, multifocal or diffuse pulmonary cystic disease, you look for the associated radiological findings. That is either ground glass opacities or the presence of nodules. So if there are ground glass opacities, there are three entities that come under this list. That is pneumocystis carinii pneumonia, lymphocytic interstitial pneumonia, and desquamative interstitial pneumonia. Whereas with nodules, you have cystic metastasis, you have amyloidosis, and you have pulmonary Langerhans cell histiocytosis. Actually, these entities form a type of interstitial lung disease, and we'll be discussing this under that topic separately. So I'm going to skip over this and go directly to conditions in which you only have cysts and no other pulmonary parenchymal finding. So there are two such diseases. One is lymphangioliomyomatosis, in which you have multiple cysts 2 to 10 millimeter or 0.2 to 1 centimeter in size, which are usually round and diffusely affect the lung. Okay, and because these cysts are present in a subpleural location, you can get a pneumothorax. Now, this disease also tends to form balls of fibroblasts within the draining lymphatics, and the lymphatic structure is abnormal. So as a result, there you may have some accumulation of lymphatic fluid within the airway, so you can get a chylothorax also. Okay. Similarly, there is another disease called Burt-Hodge-Dubé syndrome, which is a genetic disorder, which has again got multiple diffuse cysts of variable size. Importantly, Burt-Hodge-Dubé syndrome is one of the only situations in which you can have lobulated and multiloculated cysts. Okay, so whenever you have an internal septum within your cyst, you must consider Burt-Hodge-Dubé. And Burt-Hodge-Dubé as such doesn't have any pulmonary symptomatology associated with it. Rarely a pneumothorax, but otherwise usually it is asymptomatic. What is important, however, is Burt-Hodge-Dubé syndrome has increased risk of renal carcinomas. So renal carcinomas, specifically one with very poor prognosis, that is chromophobe carcinoma. So it is important to consider it, and the presence of these lung cysts actually is one of the major criteria in diagnosing Burt-Hodge-Dubé syndrome, which we'll come to in our discussions on renal cell carcinoma syndromes. What does this look like? So lymphangioliomyomatosis is multiple cysts 1 to 2 millimeters, diffusely located, usually round. So I hope that is clear, associated with a pneumothorax. Okay, and Burt-Hodge-Dubé is multiple cysts, multifocal in this particular case, and showing some internal septation, if that is apparent. Here also there is internal septation, so it need not be there, but if it is there, it is something that should immediately pique your interest. Now, importantly, this is because of a case that I was recently privy to. Lymphocytic interstitial pneumonia again may show such large multifocal cysts. There are some findings in lymphocytic interstitial pneumonia that are highly specific. That is the presence of a mural nodule and the presence of concomitant granulous opacities. So if that is not present in an adult patient, particularly a male patient, because lymphocytic interstitial pneumonia is typically more common in females, and if there is no clear association of lymphocytic interstitial pneumonia, you must consider Burtholz-Dubé syndrome. So we'll discuss the varying multiple associations of LIP in our discussion on non-fibrotic ILDs, but this is something that you must keep in mind. So that concludes our discussion, and I'll see you next time.